doctor. She worked in Amanuel Mental Specialized Hospital, and currently she's working as assistant professor of psychiatry in Kalkidan University. So I will call upon Dr. Kalkidan to presenting the association between suicidal ideation among Ethiopian physicians. As you know, one of us lost a person due to suicide, I hope. And in my experience, I know physicians, colleagues and friends who lost their lives. So this is really important topic, and thank you, Kalkidan, for choosing this relevant for our context and for Ethiopian Medical Association.
I'd love to say thank you very much for the scientific committee for choosing this topic to be presented. I really truly feel honored to be invited to such a prestigious event. So today I'll be presenting about suicidal ideation in attempt among Ethiopian physicians. This research was done in 2022. I declare that I have no conflict of interest. So these are my outlines. Worldwide studies show that suicide causes half of all violent deaths in the world, and 1 million deaths worldwide occur each year. So every 1.5 seconds, people attempt suicide, and every 40 seconds, 1% dies because of suicide. So in the US, research done shows that 400 physicians die every year because of suicide. So because of our extreme nature of medical profession, due to our extreme nature of medical profession, we're more predisposed to suicidal ideations and attempts, which is significantly different from the general population. Studies done worldwide show that the difference in our society and culture is suicide is a taboo topic, and it's not being explored much. And we as a physicians also don't recognize that we're in pain and that we're wounded healers. So, and also concerns about time, scarce stigma and care impact prevents medical professionals from receiving mental health care. So, objective of this study is to assess the proportion of suicidal ideation attempts and identify suicidal factors among Ethiopian physicians. And the specific objective is to assess the ideation attempt and also associated factors with suicidal ideations and attempts. Method was the study area was Ethiopia, excluding Tigray region because in 2022, because of the ongoing conflict in internet unavailability, we were not able to collect data there. And the other thing is, study period was around 3 months between July and September 2022. The design was national-wide electronic survey with cross-sectional study design, and the sampling method was non-probability, combined sampling. Source population was the physicians practicing and living throughout Ethiopia. We excluded people who are not living in the country and interns. So the study population was Ethiopian physicians who are part of different online platforms like Hacking Bridge, EMA, and EMA, the EMA platform. So the data collection, we used Google Form structured self-administered questions. The Colombian suicidal severity rating scale to assess the suicidal behaviors, in the patient questionnaire to assess the depression of the participants, and the K6 to assess psychological distress, and also the attitude towards suicide to assess the understanding knowledge of our physicians in their attitudes towards suicide. So the data, when it comes to the data analysis, we used Excel query for data cleaning and coding, and we transferred it to IBM SPSS version 26. And for descriptive analysis, we use descriptive analysis to summarize profile of the outcomes and the independent variables. Also, to assess the association, first we used chi-square test and was the values which showed significant association were then further put into a binary logistic regression model. So the independent variables were chosen or selected based on previous evidences and existing literature. So the p-value for the association was 0.05 and confidence interval was 95%. So when it comes to the data quality control, we assessed the feasibility of the questionnaires and the paper on 20% before we started collecting data overall in the country. And its kind considerations, we had its kind tolerance of A from A and ground besides having report. So the other thing we did was we gave the paper to EMA to check it out before it was distributed to members. Also, data analysis secrecy of the data collected were important for the participants. And anyone who was having problems, we gave our contact information and places which provide mental health providers for them if they have any problems during when they assess themselves, if they were suicidal or other problems they were facing. So when it comes to the results and discussion, the socio-demographic character of the participants there were 657 participants in this research, and 7 of them were discarded because of data incompleteness and unreliability. Other than that, from 650 participants, 65% were male, and mean age of the participants was 29. It's between 24 and 35 years old, and most of our participants, around 40%, were single, and 50% of the participants were residing in Addis Ababa at the time of the study. So the other thing we noticed was from our participants, 4% were unemployed, and the other 5% were not practicing medicine at the time we did the research. In the median income were 11,000 per. So from our participants, 44% were general practitioners, 32% were residents, 20% were specialists, and 2% were sub-specialists or fellows. So majority of our participants practiced between 1 up to 5 years. And so one of the things that we assessed was psychological distress and depression. In the past year, during the time of our research, 33.85% of the participants claimed to have depressed mood and loss of interest in 2 weeks when we evaluated, when they did the research. So 40.3% of the participants reported having suicidal and depressed mood during those times, and also 69.5% of the participants were reporting to have psychological distress. Besides that, almost 32% of the participants were reporting to have substance use. Out of this, 10% of them were reporting that the fact that they are using substances affecting their life, their functionality, and their work. And from this study, cannabis use was 6%, and opioid use was around 2%, which was relatively higher compared to other studies. And also comparing these results with US, German, and Norwegian studies, the depression rate seems to be relatively similar, but in our setup, it seems to be higher. So the other thing we assessed was attitude of physicians towards suicide. So we classified people who think suicide can happen to anyone, and it is somehow human right for someone to decide to kill themselves as a positive attitude towards suicide, and the negative attitude was someone who is more restricted about it and would not allow for people to commit suicide, or people who say it's unacceptable. So most of our physicians say that suicide is not unacceptable. And the other thing is when they are asked, when they encounter patients or families or friends who actually committed or attempted suicide, how they feel, they mentioned they feel more anger, disgust, and mixed feelings rather than empathy. So So the other thing is, from our participants, around 25% of the physicians mentioned that they believe suicide happens because of body splits. So when it comes to suicidal ideation and attempt, our participants reported that 33.5% of them had suicidal ideation overall in their lifetime. And in the year of the study, 15.5% of our physicians were having suicidal ideation. This indicates the result is higher than the general population, which is almost like 7%, 8%. But compared to the worldwide studies, it's lower than Europe, North and South America. But there is no, to the best of the author's knowledge, there is no research done in Africa specifically on this topic. So I couldn't compare it to African studies. But compared to the general population, the ideations are higher, but the attempt is lower than the general population. So similar to the outside studies, the female population have 1.5 times higher risk than the male physicians. So when it comes to the attempt, almost 8.3% of the physicians claim that they have attempted suicide. That's the lifetime prevalence. But in the year of the study, 2.6% of the physicians attempted suicide. This result is still higher than the European and South American results. The Norwegian result shows that the suicidal attempt among physicians is 1.3%. So it needs further study to show like what made our physicians have more attempts or more ideations. So the other thing we assessed was frequency of suicidal ideation among Ethiopian physicians. 45% of the participants mentioned that they have suicidal ideation most of the time, or some often, which is like 1%. 1% of them say that they have this ideation all the time. So we assessed the severity or the intensity of suicidal ideation, and it shows like 4% of the participants mentioned that they had active suicide with a specific planning intent. Majority of them have passive days wishes, as if like, what if God takes me, or what if I sleep and never wake up, while the others have non-specific suicidal thoughts, or thinking that what if a car hits me, or something like that. But rare numbers are around 8%. They have active suicidal ideation with some intent, but it's not strongly pursued. So what makes our suicidal ideation attempt among physicians different is the high lethal mechanism they mentioned to use. So the first number one choice all over the world among physicians is to use overdoses or lethal mechanisms. Our participants mentioned medication overdose with barbiturates, rates, amitriptylines, and diazepam. What was so peculiarly different from other country studies, around 4 participants mentioned to use KCL, IV KCL, to actually end themselves. And 9.2% reported that they have parasuicidal behaviors and they engage themselves in a highly risk behavior because of their emotional or other situations. So the association factors we evaluated were like I said, we started with chi-square, and with significant p-value above 0.05, we tried to do binary regression, and the most independent factors we found to be associated with suicidal ideation and attempt was from family history of suicidal ideation and attitude towards suicide. The other things, linear association was being a female, age less than 35, and also income less than 15,000, and current practice in Addis Ababa were associated with suicidal ideations. Also, for both suicidal ideation and attempts, psychological distress and depressive symptoms were one of the associated factors that were seen. The other thing I didn't mention was different departments were assessed. We tried to see how the psychological distress and the suicide was correlated with different departments. So Department of Family Medicine, Anesthesia, and Psychiatry tend to have higher level of suicidal ideation and attempt, but our participants in Anesthesia and Family Medicine, their number was less than 20. So we cannot for sure say that it's a relevant number, so it needs further study with more well stratified and adequate number of physicians. So in conclusion, from this study you can see high prevalence of suicidal ideation among our physicians. Majority have frequent thoughts, and female physicians tend to have higher risk in suicidal ideation attempt. Compared to the males, females have 42% of ideation and almost 11% of attempt, and mechanisms that is highly lethal, and our physicians reported high level of depressive symptoms and psychological distress. So, according to WHO, Ethiopia, and like some studies, you can see we have physician shortage, which is like we have one doctor for 10,000 population and less number of specialists. This shortage coupled with significant high suicidal rates among physicians signifies the urgency of addressing mental health concern in our medical workforce. So, after looking at this, what we recommended was for different stakeholders, for example, for Ministry of Health and Health, for Ministry of Education, we might need to have a policy reform. Like trying to educate our kids from elementary school to high schools, and even in middle schools, have resiliency trainings or psychological mindedness, and also to be educational and awareness or different webinars preparing our physicians and other people to understand mental illness and to decrease stigma towards this. Also, community support network. After looking at this study, what we are trying to do as a consequence of MHHP or Mental Health for Health project, we tried to take our problem on our hands, and we hope that every physician who's going through this or who knows someone in pain to do this. So I believe we are responsible beyond those people in power to do this for other people. So we recommend everyone to be engaged and help people who are in stress or distress. And so the other thing is we recommend hospitals and the management team to actually work on these things, on trainings, for example, building facilities which give free therapies or other things in the hospital setup that physicians or our students will not feel have stigmatized or feel biased due to mental health. So the other thing we need is additional research, longitudinal research or qualitative studies to understand what's so different about this culture, this population, and how we can actually impact this pain, and we can change it or we can help ourselves. So I would like to acknowledge my advisor, Professor Talayanan, Dr. Wali Fukalo, also Dr. Kalkidan, and all the participants of this study, Ethiopian physicians, EMA, Hakim Page, Nawa, and everyone was thank you very much. If you have any question.
Thank you, Dr. Kalkidan. That was a very insightful presentation. So we're going to collect questions from our audience, and the moderators will be able to ask a question if they want as well. So